and that is Professor Colwyn Jones. And Colwyn is an honorary professor in dental public health at the School of Dentistry here in Dundee. And Colwyn has had a very illustrious and varied career, and we're really privileged to have him here today. Colwyn's role within the European Association of Dental Public Health spans many years. He was president of the association and from 2017 to 2019, and has been the chair of the Special Interest Group on Oral Cancer Prevention, and continues to hold that role today. He has worked within the National Health Service in Scotland as a consultant in dental public health for a number of the territorial boards, which are based in local communities, but also at national level within NHS Scotland. He's well regarded in the field and has been awarded the BDA, the British Dental Association Fellowship, in May 2017 for outstanding and distinguished service to the dental profession and the British Dental Association. So Colwyn, you're very welcome to this webinar this morning. We're absolutely delighted to have you speak, and I'm going to hand over the mic and the screen to you just now.
Fantastic. Thanks, Niall, and good to see everybody here this morning. Good to see such a large number of people. I'll just see if I can share my screen here. Now, can people see the screen okay?
Yes, Colwyn, that's coming through. Thank you.
Yeah, excellent. And you can hear me okay?
Yeah, I can hear you loud and clear.
Okay, thanks very much. So today I'm going to talk about oral cancer prevention as just trying to advance my slide here. My slides don't seem to be going forward. I don't know, Niall, if that would be something that...
I can share the screen, Colwyn, using your slide set if that would be easier, if you're having issues moving it.
Okay, I'm stuck on the first slide here. I'm just unless anyone's got any suggestions about how I might change that.
It would need to be through your screen on your side. We won't have any access to moving it. But I'm happy to, I can share screen and advance the slide for you if you just...
Okay, I'm having trouble moving the screen forward. Can we go to the next slide, please?
So if you stop sharing, Colwyn, I'll share from my side, and then I'll take control.
Okay.
Just give me one moment. Okay, so are colleagues seeing that?
I can certainly see it, yeah.
Okay, so next slide. Here we go.
Okay, it's been largely covered by your introduction. The Special Interest Group in Oral Cancer Prevention was one of the first groups to be established for the European Association. And with the reorganisation of the Special Interest Groups, we're now the one of the Health Promotion and Disease Prevention Special Interest Group. And we're running this seminar today with Balance, the Borderless Alliance, to try and increase the amount of research that's done in across borders here. Can we go to the next slide, please? Okay, the title of the oral cancer of the Special Interest Group is Oral Cancer Prevention, and really today I'll be looking at primary prevention. So this is before cancer has had the chance to develop. Looking at the WHO GloboCan website, it suggests there's about 20 million cases of cancer. This is all cancer. This is not oral cancer. There's about 20 million cases of cancer every year in the world, and about half of those people who have cancer die each year. So it's a huge burden. It's a huge health burden on the population. Next slide, please. And if you could just press the advance button again. again, this is using a paper, Gormley in the British Dental Journal a couple of years ago, 3 years ago, looking at head and neck cancer. And they reckon that in his paper, he reported there were about 660,000 cases of head and neck cancer in the world every year. And looking at the global incidence of all cancers, they reckoned that for head and neck cancer, it was about 3.3%. So not a huge total, a huge part of the total cancer burden, but quite a substantial part. And the reason I put not oral cancer is because in Scotland, in the UK anyway, we talk about head and neck cancer. Head and neck cancer is slightly wider. It includes other parts of the head and neck, obviously, the larynx, the pharynx, and so on, which might not be normally included in oral cancer. And I'll come to cover that in a minute. Next slide, please. Just the final thing from that slide, again, for oral cancer, about half of the cases, the mortality rate is about 50%, very similar to overall cancer. This is the cover of the International Classification of Diseases by the World Health Organization. This is ICD-10. I know that the WHO is working on ICD-11, which is going to be the next revision. There are always new diseases that come along, and the human diseases that need to be updated, and the causes and so on are reclassified and so on. But currently, the 10th, certainly in the UK, the 10th ICD-10 is the one that's used. It's used in two ways. One is on death certificates, so that we know that from mortality from death certificates what people died from. It's a very, very useful source of information and so on. But there are also diseases that are notifiable. And cancer in the UK, certainly, I think in most countries, cancer is notifiable. And you have to know what you're notifying. So the ICD-10 classification is used for cancer registries, in most countries, as recommended by the World Health Organization. So it's used both for mortality, death certificates, and for cancer registries. So this is how we find out about the incidence of oral cancer cases. Next slide, please. The classification, it goes from A to Z. It's a huge, huge book. It covers all human diseases and so on. A and B are infectious and parasitic diseases. When you think about it, they're probably the commonest reasons, or were the commonest reasons for mortality. But in more recent times, things like heart disease and cancer are more likely. And looking at malignant neoplasms, looking at cancers, you can see that it's the third category, the C codes. They go from 0 to 97, which is quite a sobering thought, that we have 98 different types of cancer that can affect the human, 97 plus the 0 code, obviously. 97, potentially 97 different cancers that have been recognized in humans. And if we just look at the head and neck, we use categories C0 to C14. So there are potentially 15 malignant neoplasms, 15 cancers of the lip, oral cancer, and oral cavity and pharynx that can affect that. There can be other cancers that affect the head and neck, usually metastatic disease from other from other cancers, other parts of the body that can metastasize to the head and neck area. But again, it just gives you that indication of the number of different types of cancer that can develop there. Next slide, please. So in the UK, we've got head and neck cancer. We use the ICD codes 0 to 14, plus the ones for the nose, larynx, middle ear, and sinus, and so on. So the data I'm going to present today, some of the data anyway, is head and neck cancer in the UK. But most of the data that's provided by the World Health Organization is through the International Agency for Research on Cancer, and that looks at cancer of the lip and oral cavity, which is C0 to C number 6. So that the actual figures, when we're trying to do comparisons, they roughly match, but we know that the head and neck cancer figures in the UK are going to be slightly higher than they are for other countries, and we can take that into account. And you can see here the other cancers that affect the oral cavity and surrounding area there. Okay, next slide, please. Oral cancer is a terrible disease to get. It doesn't matter whether you're just the suspicion of it, but the treatment for oral cancer is usually pretty devastating. If you think about a very advanced cancer, stage 4 cancer, which is going to involve resection, radiotherapy, perhaps tissue transplants to try and reconstruct the area, right through to somebody who's got a lesion, you don't know what it is, they get referred for a biopsy. They obviously would know that if they're being referred for a biopsy, that there is a risk of that it could be a cancerous lesion. And even if it's clear, even if they've been found, the biopsy shows there's no cancer, it's nothing to worry about, there's still the psychological effect of the investigation there. Even if they're reassured and so on, there will be a proportion of patients who continue to worry and have concerns that they may, if they don't have oral cancer now, could they go on to develop it in the future? So it's just to say that I'm not saying we shouldn't do it or anything like that. It's just that when we're working with patients with oral cancer, we need to be very, very aware that any investigation is going to have could potentially have the side effect of a psychological effect on patients. And we need to be cognizant of that and make sure that they're taken care of from that point of view. To me, you know, as a dentist, I think it's a privilege to be able to work in the mouth, to study the area, the complexity, the diversity of structures and so on in the head and neck area. You know, it really has been a privilege to do that. But it is a difficult area to work in, and you know, oral cavity cancer, once an oral cavity cancer develops, it's a terrible, terrible disease, which is why I helped to establish the oral cancer prevention to see if special interest group to see if we can actually prevent oral cancer. Next slide, please. Okay, if we look at oral cavity cases, so again, cancer cases, so this is from the IARC website, the GloboCan website. If you could press the button again, please. And do you remember that head and neck cancer was about 3.3%? For oral cavity cancer, lip and oral cavity, it's a bit less. It's just under 3% of cancers. So we're in the right ballpark. We think that oral cavity cancer, it's not that common a cancer, but it's not a rare cancer. It is a problem. Just looking at the numbers there between males and females, it looks like males have about twice the incidence of oral cancer than females. And that's a fairly common finding, usually looking at geographical areas, looking at different countries. And irrespective of the actual level of incidence of oral cancer, the male rate has always been higher than female, usually about twice as high, although we think that that's changing, and we'll discuss some of the reasons for that later. Next slide, please. Okay, I'm going to talk about some Scottish data now. This is a rather cheeky cartoon here. The stereotypical Scotsman there in his kilt. Obviously, I've got my kilt on today, but you can't see it because you can only see my head and shoulders. And just a comment about Brexit, it was an England and Wales issue. Next button, please. There's actually a mistake in this, that Northern Ireland voted to remain as well. I feel very strongly part of the European Union, and I wish we hadn't left the European Union, but there we are. That's democracy, and we have to live with that now. Next slide, please. And this is, it's not all 20 the commonest cancers in Scotland. It's the top 5 or 6 or 7 cancers in Scotland. This came off the Public Health Scotland website a few days ago. And you can see that the commonest cancer between males and females is lung cancer, trachea, bronchus, and lung cancer. Probably related to smoking, some air pollution as well. The second commonest disease is breast cancer. It's almost all, there are a very small number of male cases, but it's obviously almost exclusively a female case. Prostate cancer is the third. It is exclusively a male condition there. I'm talking about sex here, not gender. Colorectal cancer or bowel cancer is the fourth. Malignant melanoma of the skin. I was surprised at that. I live in Scotland. We don't get a lot of sunshine in Scotland. So I was quite surprised that malignant melanoma is such high up the league there. But then when I think about it, when the sun does shine in Scotland, all the Scottish people rush out into the sunshine without sunscreen, without any protection, to try and benefit from it before it disappears again. So perhaps it's not so surprising. And then sixth there is head and neck cancer. So currently in Scotland, a northern European country, it's about the 6th commonest cancer. In some parts of the world, it's higher up the league, and in other parts of the world, it's a bit lower down. But it's roughly that sort of level in most countries. Next slide, please. Wow, this is Scotland looking at the number of cases of head and neck cancer between 1993 and 2023, 31 year. And you can see there that the incidence of oral cancer, or head and neck cancer in this case, has absolutely rocketed. Scotland has got about just over 5 million people, just under 5.5 million people. So that there is quite a lot of variation in the number of cases each year. I don't know what happened in 2013. In 2020, the number of cases dropped, which probably was related to COVID, but it's come back up again. So this is a shocking trend to me. It looks like the incidence of oral cancers, incidence of oral cancer in Scotland is rocketing. Next button, please. But it's a wow graph here. You'll see that it doesn't go down to 0. So the gradient of the best fit regression line there is exaggerated because it doesn't go down to nothing there. There may be other reasons why this graph is so steep. One may simply be that the population has risen. The population of Scotland has risen so high that the number of cases has rocketed as well. And the population of Scotland has risen slightly, but not by a huge degree. But that might account for some of the increase there. The other thing is that people in Scotland, despite our reputation, people in Scotland are living longer. So this may simply be a fact that because people are over this 30-year period, our life expectancy has increased. The number of people with oral cancer has increased simply because of that. We're living longer. Traditionally, oral cancer has been a condition found in older people. So to try and correct for this, to try and correct for population size and for changes in life expectancy, what we can do is we can standardize. And if you, next slide, please. If you look at the next slide, what we've done here is we've standardized it to the world age and sex rate, the age standardized incidence rate using the world population. And we can see here that the graph is much less steep, but it is still increasing. Using the world age standardized rate might be, because our life expectancy is pretty good in Scotland, not as good as it could be, but it's still pretty good. This may not be the best way to standardize for age and so on, but it does show that even after we've corrected for that, or perhaps even overcorrected with this world age standardization, that the rate of oral cancer is rising slightly. I know the y-axis on the side there doesn't go down to 0 again, so that gradient was once again slightly exaggerated, but it is increasing. So certainly in Scotland, it doesn't matter how you look at the data, certainly the number of cases is increasing. And we think that overall, the proportion in the population, irrespective of the size of the population or the age of the population, is also increasing. Next slide, please. I'm just aware the local council are cutting down a tree in the street outside my house here. I can hear the noise of the chainsaws and the work going on there. I'm hoping it's not affecting the audio too much here. But I shall continue anyway. I'm just worried that the tree's going to fall on the house in a minute. That would be the worst outcome.
We can't hear anything at the minute, Colin, so we'll look for crashing trees.
Okay, sorry about the change there. Okay, this is again data from the GloboCan website, the International Agency for Research in Cancer, and it's looking at the different parts of the world. It doesn't have a European figure there. It's got a Northern European figure there of just under 5. I guess I would consider myself being in Northern Europe here, or perhaps Western Europe is a little bit lower than that. But you can see that the rate of cancer, the incidence of cancer, varies from just under 15 per 100,000 down to 1 or 2 per 100,000, very low rates. So this gives us some idea of the spread of cancer across different countries here. So they're the blue figures on the left-hand side of the screen. The red figures are the mortality. I wasn't really going to mention mortality here at all, but about 5 or 6 or 7 from the bottom is Micronesia. They don't have a very high rate of oral cancer incidence, and they don't seem to have a very high rate of mortality from oral cancer. One explanation for that might be when I was talking about death certificates and so on, about the ICD codes. People don't die from oral cancer. It kills them, but they usually die from a condition, pneumonia, heart failure. It's usually some other condition. It's rare that oral cancer will be the only cause of death for that. There's some other organ that will be affected, cachexia and so on. And the fact that there's very low mortality there suggests that perhaps the way they record deaths in that country, they only record the primary cause of death, which in many oral cancer cases will be probably pneumonia. But there may well be differences in different parts of the world. But we're really just concentrating on incidence today. You can see that there's a huge, what was it, about sevenfold difference in incidence in different parts of the world. Melanesia, the real issue is Papua New Guinea. Next slide, please. I didn't know where Melanesia was. I had to go and look it up, but you can see it's Papua New Guinea is the main geographical, the main country there, and there's a number of other smaller countries there as well, just north of Australia, northeast of Australia and New Zealand there. So that's Melanesia. Next slide, please. And this was some data I got off the World Cancer Research Fund website a couple of days ago, just looking at the number of cases. So the total number of cases, as we found earlier, is about 390,000 there. And that gives a world rate of about 4 per 100,000. We think that the most number of cases that are reported is in India. India's got a huge population, so there will be a large number of cases. But if we standardize that, we can see it's about 2.5 times the world rate. China provides the next total number, again, a huge population, but their incidence rate of oral cancer is only 1.5. It's less than half of the world population. And that's an interesting find. The United States is there. Bangladesh, Pakistan, again, have got very high rates and so on. The French metropolitan area, I'm assuming that's Paris and other cities is higher than the world rate. It's a good bit higher. I was going to stereotype French drinking absinthe and smoking Gauloise and so on, but that's certainly an interesting finding in France there. Next slide, please. So we've got a global rate of 4 cases per 100,000 population. In Europe, in continental Europe, all European countries, not just the European Union, you can see that it's very similar, slightly higher there. In the United Kingdom, it's higher still. There may well be various reasons for that. Smoking, alcohol intake, so on, the levels of poverty in the UK and so on. Looking at India and Pakistan and Papua New Guinea, which is the highest in the world. So there is quite a variation, a variety in incidence rates across the world. Next slide, please. So this is from a paper that was in the British Medical Journal looking at head and neck cancer. It's a few years old. It's, well, it's 15 years old now, the paper is. It was a review of head and neck cancer, and most cases previously were in older people. More than half of them were in people over 60, and almost all of them were people in over 40. We think that is changing slightly, in that there are more cases in younger people. Back in 15 years ago, the male to female ratio was 4 to 1, which has changed. We think it's about 2 to 1 now. Male rates in some places are declining, in other places aren't. And female rates in most places are increasing. So the change in ratio, male to female, is because the males, we think, are slightly improving, whereas females are rising up. And it may be due to things like smoking incidence and so on. And in this paper, the authors said that 75% of all of the cases of oral cancer were found in people that smoked or drink or used smokeless tobacco and drank alcohol. So that is the background. We're starting to look at the etiology of oral cancer now. Next slide, please. The other issue to look at is inequalities. This is a definition from a colleague or an ex-colleague, somebody I used to work with, Jerry McCartney at the University of Glasgow, and it's unavoidable and unfair differences in health. Health inequalities, it's not a gap, it's a gradient. It doesn't matter how you rank a population. You get a gap if you dichotomize population into, you know, high and low, with two categories. But if you look at 3, 5, 100 categories, there is, for almost all the human diseases, there is a gradient, health inequalities gradient, usually ranked by poverty or some other measure of socioeconomic, some other socioeconomic measure. Next slide, please. And the WHO recognized this. As I've said, it's a gap. You only get a gap if you look at 2 groups. Also, health inequalities are not confined to the poor. They do run right across the gradient, right across society. Next slide, please. So this is looking at some head and neck cancer data from Scotland, and what we've managed to do with the population here, or not the population, the patients, the people that have developed head and neck cancer, is we've used their zip code, their home postcode, to categorize them into 5 categories. It's called the Scottish Index of Multiple Deprivation, and in quintiles, 5 categories. If you're interested, you can go and read about it. It's you know, it's an algorithm. It's so complicated that certainly I can't understand it. The bluish green bars are the incidence, and you can see in the most affluent, the least deprived group, it's about 10 or 11 cases per 100,000, going on a gradient, probably not a linear gradient here. It looks like it's almost a logarithmic gradient up to the most deprived quintile, the most deprived 20% of people who developed oral cancer. And the rate in the most deprived group is 3 times the rate, almost 3 times the rate in the most affluent group. So oral cancer, the same as almost every other human disease, almost every other human condition, shows this social class gradient in oral cancer incidence. The grey line is mortality, and you can see there that there's also a gradient in mortality. That's more affected by access to care and so on. We like to think we've got good access to care in the United Kingdom and Scotland, but we still get this gradient in mortality as well. Okay, next slide, please. Moving on to oral cancer types. The vast majority of cancers, oral cancers, head and neck, lip cancers, are squamous cell carcinomas. I've put more than 90% there. It's probably more than 95%. And all of the other malignancies, all of the other cancers that can develop in the head and neck or in the lip and oral cavity are they're quite small numbers, sorry, not small numbers, quite small percentages. The vast majority are squamous cell carcinoma. So we're going to look at squamous cell carcinoma and the causes of that first. Next slide, please. So there we are, squamous cell carcinoma. We're covered in it. It's our skin is a squamous cell. Is a squamous cell epithelium, stratified squamous epithelium. We're covered in it. It's what keeps us away from our environment there. Next slide. It's our skin. It also lines the inside of our gut in various parts. There are variations. So we have the basal layer. And it's the basal layer that's affected by carcinoma. There's something that gets in there, changes the way that the basal layer multiplies. It becomes out of control. It starts to increase cell production there in an uncontrolled way, so that the carcinoma, first of all, spreads up the way into the epithelium, and also can start to spread inwards, can invade into the connective tissue underneath, so it's squamous cell carcinoma. Normally, for stratified squamous epithelium, we've got a biofilm on the outside, obviously. The bacteria, yeasts, whatever gets there, carcinogens and all the rest of it, and they would be sloughed off as the basal layer grows. So it's a protective mechanism to make sure we don't carcinogens and so on don't get into the basal layer and affect the basal layer. But for squamous cell carcinoma, there has to be a change in that basal layer that causes carcinoma. Next slide, please. So let's look at some exposures. This is a paper, again, it's from a few years ago. It's looking at preventable exposures defined by the International Agency on Research in Cancer. Next slide, please. And looking at primary prevention of oral cancer, they came up with 5 areas where we can start to work. Smoking and tobacco, I'm sure it won't come as any surprise. Alcohol is a cause of cancer. It's a primary cause of cancer. It has been classified as a class 1 carcinogen. Diet is in there. There's something about the quality of your diet, whether you're well nourished. It looks like if people are poorly nourished, then their chances of developing oral cancer are higher. It may be that there are some protective elements in a diet which can help to, if an early cancer is developing, antioxidants and so on, if you're well nourished, your immune system is much stronger, so that in theory, diet has a very strong effect on it. Human papillomavirus. We talked earlier about incidence, male-female incidence changing. And we think that HPV, just the same as it causes cervical cancer, we think that HPV is linked to a number of cases of oral cancer, or perhaps oropharyngeal cancer. Just the same as for something like herpes simplex. After you've had the primary infection, most people clear it, but sometimes the viral DNA can survive inside a cell where it's hidden away from the immune system. And at some stage later, for various reasons, perhaps to do with immunity and so on, the virus can be reactivated, and it can affect the DNA of the cell, of the basal cell. And we think that that might be one way that human papillomavirus can be a cause of oral cancer, same as it is for cervical cancer. And we think that HPV virus, there may be a link there as to why it's changing in, the male-female ratio is changing, as well as changes. It's multifactorial perhaps, but it's also as changes in things like smoking prevalence. And one thing not to forget is sunshine, is solar radiation, UV radiation. Lip and oral cancer, squamous cell carcinoma of the lip is not uncommon. Certainly in some countries. I meant to highlight it to you earlier when we were looking at the different countries there. Australia and New Zealand have a high incidence of lip and oral cancer, which we think is due to the high levels of sunshine that they get in Australia. I was once speaking to some Spanish students, and I said a lot of the Australians play tennis. They're out in the sun all day, and of course they were outraged that Spain has got a lot of good tennis players as well. They're out practicing in the sun as well. So why is the cancer incidence higher in Australia and not in Spain? Certainly for lip cancer. And it took me a bit of time to find out, but of course the southern hemisphere, there is a hole in the ozone layer in the southern hemisphere, and there's more UV radiation down in the southern hemisphere, so that's probably the explanation. Next slide, please. This is data from the BMJ paper a few years ago. Smoking doubles your risk of developing oral cancer. Alcohol doubles your risk of developing oral cancer. The two together, I didn't use the Menhena paper from 2010, the odds ratio from that, because it was something like 13, which seemed a bit high to me. I've used the data from the Gormley paper in 2022, but there is a synergism, there is a combination between alcohol and tobacco that increases the likelihood, almost a six-fold increase in the likelihood of developing oral cancer. Diet, looking at diet, if you've for every extra portion of fruit you eat, the odds ratio is halved, and for vegetables it's halved as well. We think probably vegetables are better for you. So diet has been shown to have an effect on the likelihood of developing oral cancer. HPV, human papillomavirus, again, the odds ratio there is slightly higher. Most people that get HPV virus infection clear it, but there does seem to be a small subset of people where HPV can go on to cause oral cancers and oral pharyngeal cancers, and sunshine there. So these are the types of things we need to be looking at when we're looking at the primary prevention of oral cancer. Next slide, please. There are other factors or markers associated with oral cancers. Obesity. Now, whether obesity is a separate marker from socioeconomic status and so on, the level of obesity in a population is usually linked as well, and but obesity has been flagged. There's the paper, the BMJ paper, talked about high dietary intake of red meat or of processed meat, and certainly with processed meat that's been smoked or preserved with various chemicals and so on, the consumption of meat may be linked to it, or it may just be a marker. It may be a marker for some of the reason. Physical activity is supposed to reduce the likelihood of oral cancer, and I can remember reading an article in the last few weeks where physical activity was post cancer treatment, increasing the amount of physical activity you do was supposed to reduce the likelihood of a cancer coming back, which may well be an issue. HIV infection was flagged as a marker. we know that people with HIV are immunosuppressed, immunocompromised, and it may well be that with improved antiviral treatment and so on, where the burden of viral load and so on almost disappears or does disappear, and a lot of new treatments and so on, it may be that HIV infection may in future not be an issue. And there is Epstein-Barr virus. That's the Spanish title for it, which we know is linked to nasopharyngeal cancer. So Epstein-Barr virus, as well as the HPV virus, could indeed be a cause or a marker associated with oral cancer. And next slide, please. Looking at tobacco, there is already a huge amount of work that has been done to try and reduce the amount of tobacco that's consumed, that's sold, that's advertised, and so on. We have the WHO Framework Convention on Tobacco Control, and most countries have signed up to this. And it requires countries to take measures to protect health policy from the tobacco industry. The tobacco industry, obviously in 2003, most of the e-cigarette companies now are also owned by the tobacco industry or linked to the tobacco industry. I do know of researchers in oral cancer that haven't been allowed to, because they've accepted sponsorship from groups associated with the tobacco industry, that haven't been allowed to join things like Action on Smoking and Health, various tobacco policies to try and reduce tobacco and so on. Okay, so there's the Tobacco Convention on. We already have smoke-free working in the UK. I think most countries, this is how we got the smoking ban. It was through a health and safety approach rather than any other system. If next slide, please. And I was very fortunate. I was in Japan, and I think this was in Tokyo. It might have been Kyoto, but I think it was in Tokyo. And they actually banned smoking on the street. This is on the pavement. Which is, I think, the next move. We need to start thinking about trying to. We need to try and reduce exposure to smoking and banning smoking on the street. Again, recently I've heard that in France they're trying to ban smoking in areas where children are going to be present. And I think these are the types of ways we need to move forward, increasing the restrictions on where people are allowed to smoke. If people want to smoke, they can still do that. It's just they have to make sure they do it where it's not going to affect other people. It's not going to affect their health. Next slide, please. This is a quote from the Director General of the WHO, and raising taxes on tobacco is the most effective way to reduce consumption of, obviously, tobacco. She's talking about the other product that kills is obviously alcohol. Tobacco and alcohol. Tobacco and alcohol, I don't think we can consider them the same way as other goods, whatever you want to call it, the capitalist system, the market system of buying and selling, because people that consume tobacco and alcohol are usually addicted to it, or people consume high levels of it are usually addicted to it. So it's not that they can make choices around these products. They are addicted to it, which is why we need to have much stronger, I think, much stronger regulation around tobacco and alcohol. Next slide, please.
Thanks, Colin. Just a time check, just to let you know we're into the last 10 minutes.
Okay, thank you. So as dental public health people, I think that the blunt reality is we're unlikely to make changes on our own, but we should be working with things like other groups, public health groups, to try and introduce medical and other groups to try and make sure that dentistry is included in there, oral health is included in there, as well as general health, to do things like to ban tobacco advertising, which we have in the UK at the moment, We also need to try and ban it online. I don't know exactly how we're going to do that in the current climate, but there we are. We can reduce availability of tobacco products and so on. The time that it might be available or where it's available. I've already talked about banning smoking in public places, increasing duty, increasing tobacco tax. We have existing laws which are very poorly enforced. Things like import and smuggling and age limits on smoking. These are the things where we can make a difference. We can make a small difference. Thanks. Next slide, please. There's also an issue about smoking, smokeless tobacco. We'll probably talk about tobacco pouches subsequently soon. I can remember, it's a long time ago now, maybe 30, 40 years ago, Skoal Bandits. They were going to open a factory in near south of Glasgow in East Kilbride, I think it was, to produce Skoal Bandits, which are these little tobacco pouches which you pop under your lip. And it was they managed to stop the production of that, but it was difficult. And as far as I'm aware, the sale of smokeless tobacco is forbidden in the UK, but it doesn't mean to say people can't access it through the internet and so on. Ban on advertising, I think, should extend to smokeless tobacco. We can induce, because it's tobacco in there, we can reduce the duty on it, and then the laws and smuggling and so on. There has been this increase in electronic and e-cigarettes and vaping, ENDS, electronic nicotine delivery systems. It's not a smokeless tobacco. It may be derived from tobacco, but it's really just a nicotine delivery system. Next slide, please. And vaping is a problem, big problem, and it's getting worse. I think when NHS England said that vaping was 95% safer than smoking, I think that was a big mistake that was made. Tobacco, let's face it, everything is safer than smoking tobacco. You can swim with sharks. It's probably still safer than smoking tobacco. I think the only justification for it is that if you do smoke tobacco, you should move completely to vaping, and then you should stop using nicotine systems altogether. That's what we should be trying to encourage people to do. There is no benefit to substituting vaping for partial use of tobacco. And in fact, it makes it worse. There you're getting all the carcinogens and so on from tobacco, but you're getting all the harm from vaping as well. So vaping as a way to, for people to stop smoking cessation would be good, but I currently don't think the way it's being rolled out, certainly in the UK and other countries, is beneficial. If you don't smoke tobacco, if you're not a smoker, then you shouldn't start vaping. Nicotine is harmful. Nicotine, we know, it gives you a buzz. It gives you a very short, euphoric feeling on inhalation, but it is harmful. It affects the cardiovascular system and so on. Next slide, please. This is the electronic cigarette shop just up the road from me. It's about 500 yards away from me as I sit here. Electronic cigarettes you can trust. Next slide. There have already been problems. EVALI was a problem, I think it's about 3-4 years ago. EVALI stood for e-cigarette vaping associated lung injury. And it was actually caused by contamination. People were using e-cigarettes to smoke cannabis oil. And the cannabis oil, as with a lot of illegal drugs, was cut with something similar so that you didn't notice the difference. It was cut with vitamin E acetate oil to dilute the cannabis. And the vitamin E acetate oil, when it's used in a vape and an e-cigarette, damages your lungs. I can't remember what the name was. Popcorn lung or something was the condition that appeared on the radiographs of people with EVALI. So already electronic cigarettes are a major cause. And simply using vaping, how can inhaling a superheated vapor into your lungs are so delicate. Blood vessels and air sacs so close together, 1 or 2 cells between them. There's no way that they can't be damaged by vaping. I always think this is interesting. If you look at the shop inside there, you can see there's a fire extinguisher on the right-hand side. It's a water fire extinguisher, which is something you shouldn't use for lithium polymer batteries, which is what are used in e-cigarettes. You should use a dry powder extinguisher or a foam extinguisher. But even better is the no smoking sign you can see on the counter there. Just beggars belief. Anyway, next slide, please. There it is, yeah. So vaping, the only thing that vaping does is to guarantee nicotine addiction, often at very high doses. We know that a lot of vapes that are available are much higher than the 20 milligrams that in theory should be the maximum amount. Vaping, I said it, the nicotine causes cardiovascular effects. It can cause hypertension and all the rest of it. Also, if it's absorbed locally, it reduces perfusion, we think anyway. We think this is how tobacco works as well. It reduces local perfusion by, the number of white blood cells that can get into your mouth, into the tissues in your mouth. So if you do have any periodontal disease, the swelling, the bleeding, whatever you have, is going to be much less than it normally would be, so that the periodontal condition progresses faster. So with vaping, we do expect people who vape to have higher periodontal disease. And I've put down here for quitting it, vaping is no better than other nicotine replacement for gums or patches. Now, people might think that's that's wrong. Contentious. They may not think that's correct. A lot of people do benefit from vaping as a way to giving up tobacco, which is good. But vapes are freely available in every supermarket, in every corner shop, certainly in the UK. Whereas patches and gum at a level, rather than the very low levels, but at levels that are going to be likely to help somebody to give up tobacco, they have to be on prescription. So the access to these other nicotine replacement treatments is much more difficult. And I think once you take that into account, I doubt very much whether vaping is more effective than patches or gum. Next slide, please. There are other issues which probably are less of a problem certainly in Scotland, not totally. Betel nut is something that's a problem in many countries. And we know that it is imported into the UK. Betel nut, it can be taken on its own, or it can be produced into what's called a quid, just the same as like a nicotine patch, often with tobacco, not always. But betel nut, we know, is independently carcinogenic. So that I can imagine the combination of betel nut and tobacco is going to be pretty bad. And again, this paper in the BDJ a couple of years ago suggested there's going to be a 7-fold increase in using betel nuts. Next slide, please.
Colin, do you mind if I just pause you there? We're just now coming to midday. And I wondered if, because I think some colleagues may have to move on at midday. So I wondered if we could bring Zainab in now just to quickly discuss the opportunities for collaboration going forward. And then we'll come back to the rest of your slides, if that's okay. And colleagues that are able to remain can pick up the rest. So I'm just going to stop just now and bring Zainab in. Zainab, if you wanted to share your slides so that colleagues are aware about the meeting that's coming up in July.
Thank you so much, Niall. I'll quickly share my slides. And I've already put in the chat link to our network for people who are interested in joining. Can you see the slide?
Yes, that's it appearing just now.
Okay, perfect. So just a quick background. We've been quite fortunate to have been supported by the Scottish charity Let's Talk About Mouth Cancer, who supported our group's activities for the last 3 years. We're now looking, as we've been expanding our membership, we're looking to apply for further funding and do some collaborative research. And this is one of the opportunities that is coming up that we are interested in applying. This is for Cost Action Network funding. For those who are unfamiliar, COST is a European corporation in science and technology, and they create interdisciplinary research networks across Europe, which makes it perfect for us because their focus is on training, knowledge sharing, international collaboration, and it aligns very well with our mission. So when I say collaboration, what I mean is that we're looking for European partners, specifically head and neck cancer researchers, early career scientists, or established research centers who can commit to this collaboration. The kind of research activities that we envision are around hands-on collaborative data collection, hands-on training, networking, some knowledge exchange programs, capacity building initiatives. We want to create tangible research outputs. So if anyone in the audience is interested in being a part of it, please do reach out to us. The other thing I want to bring your attention to is collaborative research projects. And this is just one of the ideas that we've been thinking about, is to do some sort of research around nicotine pouches and oral health. We've noticed that there's quite a bit of gap, and these products have been in the market for quite some time, and we have limited safety data. They're used globally, more so in South Asia. This is also an area that's been identified by EADPH as a priority area. So if anyone's interested or has any idea regarding any other area that they want to be a part of, or we've also thought of an opportunity to do some sort of a scoping review or systematic review to identify research priorities in head and neck cancer, specifically targeted for early career researchers. So again, if this is something that you'd want to be a part of, we would highly welcome your interest and your feedback. And if you are interested, please reach out to us, either write to us on our email, or we'll also drop our individual emails. And we are holding a meeting on the 23rd of July, 11 a.m. UK time, so similar time, to work with an expanded working group and identify the next course of action, next research area that we can do some collaborative work in. So I'll stop sharing my screen now.
Great, thanks for that, Zainab. And the meeting that we're holding in July is online and is open to all colleagues who are interested in either of those two topics. The idea is to bring us together and start to think about ways that we can collaborate more closely over time to identify spaces in our diaries to work on these projects, and also with a view to colleagues who will be able to join the European Association of Dental Public Health Congress in Rome. We want to plan what we will do for that in-person workshop as part of this special interest group. So please do join us. And as Zainab said, the links to our website to register your interest are there as well. But do either email us directly and we can link you in, and that also will put our email addresses into the chat. But I'm going to take us back now to Colwyn to finish off the presentation. Colleagues that are able to stay with us, please do. If you do need to shoot off to other things, that's fine. We're still recording, and maybe you can watch it on catch up later on. So thanks.
Okay, can you hear me okay?
Yes, we can. Go ahead.
Excellent, thank you. Okay, so I just mentioned about betel nut. I also saw a comment about gutka and other smokeless tobaccos and so on. We know that they are, certainly in parts of the world, they are a major cause of oral cancer. Next slide, please. Here we are in Scotland. I was going to ask if people knew what these were, but we'll go straight to the next slide, please. Moray is a county up in the north of Scotland. It's malt whisky country. It's alcohol. Next slide, please. There's actually a bullet hole in the Moray there. I'd like to think it was a public health activist who was trying to make a point there, but I suspect it wasn't. And alcohol is a big problem. Alcohol, ethanol, whatever you want to call it, is now known to be a cause of cancer. Next slide, please. It's produced by anaerobic fermentation by yeast. It produces ATP, which is the universal energy source for every living being, and produces ethanol and carbon dioxide as a side effect. So it's pretty universal. Next slide. I think it just talks about beer, wine, and spirits. It doesn't matter what you drink, the alcohol is exactly the same. No alcoholic beverage, no alcoholic drink is any better or any worse for you than any other. They all cause harm. Next slide, please. And it's not the alcohol that's the problem. We drink the alcohol, or people drink the alcohol. I have to admit, I do myself sometimes, because it relaxes you. It gives you a buzz. The alcohol is a very small molecule. It diffuses right through the body. We absorb it through our gut into the hepatic portal vein, and it initially gets transported to the liver, but it dissolves. Not dissolves, but it progresses right through the body. It's in the liquid of every cell. It's such a small one. It gets all the way through. Most of the alcohol is converted in the liver by an enzyme called alcohol dehydrogenase. Now, some people have got a good enzyme, and some people have one that's not quite so powerful, and so on. It's an enzyme, DNA changes and all the rest of it. And it's the acetaldehyde that's produced that's the problem. In the liver, the damage that it can cause to the liver, we know that people with a high alcohol intake suffer liver damage, fatty liver, and so on. And the acetaldehyde is a very unpleasant drug. It's can be used as a fixative for fixing tissue, for examination, and so on. And it can also affect the DNA in the nucleus of our cells, making changes to the DNA. And we think that this is the likely cause of changes, to the basal layer, the oral squamous cell carcinoma I was talking about, and why they suddenly start to grow out of control. There is alcohol dehydrogenase in other parts of the body, but most of it is found in the liver. Our epithelium, it doesn't have alcohol dehydrogenase in it, the epithelium lining our guts and so on, but other metabolic pathways can metabolize alcohol, and that can also produce acetaldehyde. So that acetaldehyde can also be produced in squamous epithelium. And we think that that's probably the way that it works to damage DNA and produce oral squamous cell carcinoma. Next slide, please. This is a slide from Spain. There are 7 cancers that are linked to alcohol: gut cancer, colorectal cancer, bowel cancer, breast cancer. Looks like in 2022, they reckon about 2,000 cases of breast cancer were due to alcohol. We think that in breast cancer, what happens is the acetaldehyde that's produced actually fixes the androgens, the estrogen, progesterone, whatever, that stimulates the breast tissue to form breast cancer. We think that's how the alcohol works in those cases. Liver cancer is obviously a direct damage. Oral cavity cancer, I think that alcohol is responsible for about 1,500 cases in Spain. Then the esophagus, the pharynx, and the larynx. So these are the 7 cancers that have been linked to the intake of alcohol. Next slide, please. But alcohol's got a much worse, well, I don't know if it's worse, got other harmful issues. It causes cancer and oral cancer. It also affects blood pressure, it can cause cardiovascular disease and obesity. In a more acute sense, intake of alcohol causes violence or allows violence to take place, both interpersonal violence and domestic violence. It's a terrible indictment of our society that the amount of damage that alcohol can cause there. Also causes accidents, not just road accidents, other issues. And then we mentioned earlier about addiction, about mental health addiction and so on. So alcohol, as well as being a cause of cancer, is pretty bad for our health in many other ways. Next slide, please. So we need to be clear that there is no safe level of alcohol intake, either from the point of view of cancer development or from these other conditions. And it's very similar approach that we need to take in a primary preventive approach to ban advertising and promotion, reduce the availability of alcohol, increase alcohol duty. In Scotland, we have something called minimum unit pricing. Alcohol duty is controlled by the UK government, the Westminster government, not the local government in Scotland, and they refused to put up alcohol duty as the Scottish Parliament wanted them to do. So we introduced minimum unit pricing. If alcohol duty had been increased, then that money, that tax that had been collected would have been available for various other issues. But we had to go for minimum unit pricing, where the unit of alcohol in whatever it is, alcohol, beer, wine or spirits, was priced at 50 pence, just over 50 cents, euro cents. And there is now a proposal to take that up to 65 pence per unit of alcohol. For the vast majority of alcohol, it doesn't make the slightest difference. It's really only in supermarkets where it's been an issue, and it's to try and get rid of cheap alcohol. It's been very successful and it has been shown to work. And then enforcing existing laws would be something we need to develop, we need to work on. Next slide, please. I was down in London recently and I saw this slide, I just took it. Because we've banned alcohol promotion in Scotland, we don't have happy hours in Scotland anymore. I think we're still just as happy as we ever were. But one of the issues around when minimum unit pricing was introduced is that all alcohol promotions and things like when I go and collect my loyalty points at Sainsbury's and so on, I don't get any loyalty points for any alcohol I buy because that would be seen as a promotion. So these are ways that we can change the culture towards alcohol, which I think is a good thing. Next slide, please. This was the quote from the BMJ paper about 15 years ago. It suggested there was going to be a 37% increase in the relative risk. This was only in males, so females had been taken out, but it really was for people who drink alcohol compared to teetotal non-smokers. But we know that alcohol and tobacco working together do increase the risk of oral cancer. Next slide, please. Diet, we've already mentioned, and any intervention that's going to increase the amount of fruit and vegetables that people eat, especially unprocessed fruit and vegetables, is a good thing. Trying to improve food standards in schools and so on. Free fruit in schools would be a good thing. We have a soft drinks industry levy, the sugar tax that was introduced in the UK. We're looking at increasing the duty on, it's not a duty, the tax on the levy on the amount of sugar and so on. And I think we should also be looking at trying to reduce the levels at which the levies are brought in. But there's a lot of pushback, obviously, from the food industry on that. And something that's been postulated for a long time is to tax ultra-processed foods that have got high fat, sugar and salt content. As dentists, we're unlikely to get that pushed through on our own. We need to work with our colleagues in nutrition and medicine and so on to try and look at reducing demand for ultra-processed foods by increasing duty and taxation. Next slide, please. HPV, I've mentioned already. We think that HPV is now a cause of oral cancers and also oropharyngeal cancers. It's not every HPV that causes it, it's only specific subtypes. And we now vaccinate people against HPV. We do both males and females in the UK. Initially, it was only females because it was to try and reduce cervical cancer, which develops in the stratified squamous epithelium of the uterine cervix. I was always saying we should immunize males as well, usually around 12 years old, hopefully before they have any sexual experience, so that general herd immunity. If females do get an HPV infection, it's usually from a male, so we should be immunizing the males as well to try and reduce the chances of cervical cancer. We think it's linked to various oral cancers or throat cancers, and there are other benefits. The number of genital warts should reduce as well. Next slide, please. And if we look at the success has been with cervical cancer, which was the second commonest female cancer after breast cancer, mortality is declining. That could have been due to the cancer screening program. But the fact that the number of cases that's now being picked up, the incidence is falling, is due to HPV vaccination. And we now have a vaccine that immunizes against 9 different types of HPV, Gardasil 9. And I'm glad to say that that's being given to both males and females. I know the uptake rate isn't perhaps as high as it should be, but that's something that's worked on. It'll be interesting to see if that has any effect on oral cancer or oropharyngeal cancer in the future. Next slide, please. Finally, sun protection. Not solely, but cancer of the lip is an issue. We know that there have been campaigns, education campaigns and so on, where you slip on a t-shirt, you slap on the sunscreen and you slip on a hat, or maybe the other ones go around. I think out in Australia, they've now got slip, tap, slop, sleek and slide. So you slip that, you slap on this cream, you seek shade and you slide, I don't know, under this. So any initiative, any promotion that reduces exposure to UV radiation and so on. Sunburn is the issue. As I mentioned earlier, it's a problem in Scotland when the sun comes out. People do tend to go out in the sun. But nowadays, it is making a difference. It's almost every child, every baby you see on the beach these days has a hat on, and they are being shielded from the sun. Sunscreen. I do a bit of walking and climbing. I like being out in the hills, and it's amazing the number of my people of similar age to me, similar vintage to me, who you see are plastering on the sunscreen, many of them because they've got early changes in their skin. And wide brim hats, I don't know if we can promote that as an anti-cancer approach, but it's something that needs to be considered. And next slide. So it's been a very quick rush through looking at trying to prevent oral cancer right from the initiation, looking at those 5 factors. There's things that we as a dental profession can do. We probably need to do it, certainly looking at it from a primary cancer prevention point of view, we need to do it with our colleagues, our health promotion colleagues in different areas. And I hope that in future we can. We need to reduce the incidence of oral cancer, and by approaching it through this common risk factor approach, I think it's probably the best way to do it. I'm sorry it's taken a little bit over time, or substantially over time, but I'm happy to, I think there's a Q&A question session, so I'll be listening to any questions then. Thank you very much.
Great, thanks, Colin, for taking us through. And I'll just hopefully stop sharing slides. Yeah, so thanks very much, everybody, for joining us. And Colin, yes, great. Thanks very much for taking us through so much information to share. We were probably over ambitious with what we thought we could squeeze into an hour. But I hope colleagues have found that useful. I also hope that you found the kind of pitch that Zainab has shared there about opportunities to become involved in the future of interest. And we hope to see some of you in July. There is the opportunity now for Q&A, and if anybody has any burning questions that they want to ask, you can raise your hand, turn on your mic and camera, and ask the question directly. Zainab, I think you need to shoot off, and that's fine. I'm happy to kind of work through the last few minutes of this session.
Thanks, Niall. I can stay for another 5-6 minutes.
Okay. Go for it. And I don't think anyone's coming forward with questions at the moment, Zainab, but did you have anything that you wanted to kind of highlight or ask Colwyn?
I had a question in terms of where should our strategies for prevention be focused at or focused towards, Colin? Should it be the dentist? Should it be the wider public health community? And I know you've shed some light on it, but if you could, especially from an early career researcher perspective, what should our focus be, say, for the next 5-10 years to help with this agenda?
If I knew the answer to that, we'd be pushing ahead on that. There are groups already. I think that tobacco, vaping, tobacco pouches, alcohol, improving diet, all of these things. I think we will be more effective if we try and work with our health promotion colleagues, with our medical and nutrition colleagues, to try and in some respects, dental public health has always been doing that. We've got caries and periodontal disease to worry about, but by trying to get things like dietary improvements linked in, I'm on the Obesity Action Scotland steering group. It's always good to, don't forget dentistry as well. Don't forget, when we're trying to reduce sugar intake and so on. So I think if we can make links with our colleagues, people that are lobbying, people that are, working on all of these issues, and it's not a pessimistic view. We are making a difference. We are already. We've made huge strides on tobacco and alcohol and improving diet and so on. But we need to go further. We need to continue to improve that. And I think the only way to do that is to work with others. Working in isolation as a profession, I think it'll be a wasted effort. We should be working together with others to try and push that forward.
Thank you. And that's something that we're trying to do here at Balance, is break those silos, bring researchers together. Are there any other questions?
I think Ambrina has their hand raised. Ambrina, do you want to come in and ask your question? Just unmute yourself. You might not be able to. Or if you're not able to use the mic, Ambrina, please use the chat to ask your question, the chat function.
She's unable to unmute.
Okay, fine. Yeah, I got it. Thank you.
Oh, perfect.
Yeah. Listen, we've always been talking about, health education and behavioral changes in individuals. Perhaps we find that pretty difficult, especially young children. In our countries, like when they go to school, they have public vendors. They have on-street vendors who are selling all these tobacco pouches, Rika nut, chalia, in those fancy packets. And small children, like less than 18 years old, less than 16 years old, when we try to, educate them, convince them, we sort of, have this thing in our mind that perhaps we are crossing the lines of boundaries of, victim blaming. We try to, perhaps we do not have that, especially the teachers, they are not trained to, teach or make the children understand that these things are harmful for them. What are we doing in that aspect? I don't understand what really we are doing for those children. Can you, highlight this point and explain it?
Okay.
It's pretty difficult here managing such children.
Sure. Okay, certainly in the UK, sale of pouches and things such as that to, I think, to anybody, not just children, would be illegal in the UK. So, and it may well be in other countries that these products are illegal as well. And it goes back to what I was saying earlier about enforcing existing laws, trying to get, politicians or whoever involved in these issues to try and get them to pressure people like the police or, the health and safety people or whatever local authorities to try and address these issues. I know that they'll say, Colwyn, we've got so many other things to worry about. But this is primary prevention. This is something that we should be doing, and it'll have wider benefits, not just from oral cancer, but for all these other cancers that might be caused, and from the other health problems. I take your point about victim blaming. It's politicians, I think, use it. I think as a profession, as a medical or dental profession, we really need to avoid that. We shouldn't be saying to people, you shouldn't be smoking. And in some ways, that's why I think increasing the duty, we're not saying you can't smoke. You can smoke, but you're going to have to pay for it. It's not it's not an issue, or there's going to be restrictions on how it's available. So that's why I would take a non-victim blaming approach and try and look at a more regulatory approach to try and address some of these issues. It certainly worked in Scotland with minimum unit pricing, and I think we haven't seen much in the way of health outcomes changing yet, but I think culturally things are changing with regard to alcohol in Scotland at the moment. That may be naive, but I'm hopeful.
No, it's very interesting. And Colin, I think, thinking back to some of your slides and also the Ottawa Charter on health promotion, we're talking about healthy public policy here and creating supportive environments. So it's using those frameworks, I think, in our discussions locally and when we're advocating for change in public health policy, that we can pull back to these international agreements that are supported right across the world and look for examples in other countries. And hopefully this type of webinar and networking brings people together to kind of help and identify strategies for the particular these issues that Ambrina has raised. So hopefully that gives some food for thought, but it's possibly some work that can be continued within our networks and to learn across and think about strategies. Perhaps position statements as well may be helpful whenever we move forward. So Ambrina, stay involved in our work, because I think that it's a really interesting area and something that a lot of colleagues would want to support. Thushani, you've got your hand up. Do you have a comment or a question? Just unmute yourself and speak away. Can't hear you, Thushani.
Can you hear me?
Yes, we can hear you now. Yeah, go ahead.
Yes, I was thinking, since in Scotland, we are having a smoking cessation program. So if we can collaborate with those existing programs to introduce our oral cancer prevention, as part of research, like introducing motivational interviewing or something to improve the awareness of oral cancer among the smokers. Because I see in Scotland, the main form of tobacco is smoking. So that would be a great area of research. I'm really interested in collaborating if you have any ideas. So I think that is, I mean, without introducing new programs, if we can collaborate with existing programs, that I think that will be more successful and long lasting. That's just a comment, yeah.
Yes, I think that was always one of the driving forces behind the special interest group on oral cancer prevention, was that you know, we've got our ideas up in Scotland or wherever in England, in the UK, but there are other countries that are, you know, they've had problems, other issues. We can learn so much from each other that you know, learn the what to do, also learn what not to do. It's that issue about the lived experience, the experience of people having worked on these type of things. So that's why I see the balance group, which, you know, I think it's fantastic that we can incorporate that into the European Association special interest group and take that forward. I think it's a great opportunity to develop all of those things. As you said, Tushani, you know, it's an opportunity to do that. Yeah.
Great. Thanks, Tishani. Hopefully you'll be able to join us in July for that kind of online planning meeting as we kind of, you know, think about our way forward and identify potential research projects. So great. So it'd be really great to have you involved. So we're half an hour over time. We are the diehards, the really keen beans, for this webinar, and I'm going to draw us to a close. I don't see any hands raised or any further questions. So I thank everybody for their time. Colin, thanks very much for your time, especially the work that goes into putting slides together, checking all of the literature, getting us all up to date. We really appreciate that. So you give over an hour and a bit of your time today, but there's so many hours in the background that go into that. So very much appreciate it. Colleagues, we do hope to see a good number of you in the future in our future work. So please keep in touch. Drop your messages into the chat if you would like to keep in contact, or contact us directly via email. So thanks very much. Thanks, Colin. Bye now.
Okay, thank you.
Bye.
Bye, everyone.